Well, good afternoon, friends, and thank you so much for coming to this important session on achieving health equity for women and girls, a topic of fundamental importance to our considerations in this World Health Summit regional meeting. My name's Jane Fisher. I'm Professor of Global Health in the School of Public Health and Preventive Medicine at Monash University, and really delighted to have this opportunity to have a conversation with experts and thought leaders who are on our panel, and hopefully there will be time for some discussion with the audience. I too want to begin our session by paying our collective respects to the Wurundjeri people of the Kulin Nations on whose lands we're meeting. Pay my respects to all First Nations peoples who are here with us today, and pay my particular respects to First Nations women for their sustained commitment to the health of their families and communities. We are really privileged to have five experienced and thoughtful women presenting their perspectives today on this topic. The Honourable Jed Carney has already been introduced this morning. She's the member for Cooper. She's the Assistant Minister for Health and Aged Care, and of particular interest to us, she's the Chair of the National Women's Health Advisory Council. We also have with us Dr. Titilola Duro-Aina, who has travelled all the way from Fiji, who's the Pacific Chief of Health for the United Nations Population Fund. Professor Caroline Homer is one of the Deputy Directors of the Burnett Institute here in Melbourne, and she has particular responsibility for equity, diversity and inclusion. Professor Susan Davis is the head of the Women's Health Research Program in the School of Public Health and Preventive Medicine at Monash University, and Professor Cheryl Carcel, who's the head of the Brain Health Program at the George Institute for Global Health. We've asked our speakers to reflect on a difficult topic. We've asked them about thinking about, when it comes to achieving health equity for women and girls, how far have we come? How much further do we have to go? And what do we need to get there? We've really asked them to look forward. Everyone in this room knows that there are problems of inequalities experienced by women and girls from conception, but certainly from the earliest days of life and through the life course. We know that the health care that they seek is often insensitive, can be discriminatory and directly unhelpful. But I'd first like to ask Assistant Minister Carney to speak to us about her perspective, in particular related to policy and prioritising needs. Minister Carney, up here. Thank you.
Thank you, Jane. And I too once again acknowledge that we're on the land of the Wurundjeri people of the Kulin Nations, and I pay my respects to elders past and present. And I would also like to acknowledge Jane and all my fellow panellists. It's wonderful to be here with you all. Thank you for the invitation. I know that many of the amazing women that I'm sharing this panel with share the passion that I certainly do about women's healthcare, and I've worked with them on this issue. I'm pleased to report that I very much see women's health as building in momentum and growing in profile as an area that deserves attention. I was just catching the tram back here from another event that I was at up in Collins Street, and at the tram stop an ad came up about supporting women who have miscarried babies, and I thought, yes, this is really fantastic. It's, behind every statistic there is a story, and I think it's really wonderful that we are starting to see that out and about. So thank you to everybody who's passionate about women's health, whether it's in research, clinical practice or advocacy. My personal mission as the Assistant Minister with responsibility for this area is to shine a light on gender bias in our health system and making reforms and leading culture change so that women have the health system that they need. Now, this is a priority of mine, but it is also a priority of the entire Albanese government. Last month, we launched a 10-year action plan called Working for Women, a Strategy for Gender Equality. And the strategy outlines our vision for gender equality, an Australia where women and girls are safe, where they're treated with respect, where they have choices, and they have access to information and resources that they need. And health, I'm pleased to say, is at the heart of this strategy, because where women's health is neglected, everything else falls. Not only do women suffer, but the whole community does. Now, it's a sad fact, as good as our Australian health system is, that it does harbour entrenched gender inequality or bias. Too often, women's health conditions see terribly long delays in diagnosis, including endometriosis, with a painful average diagnosis time of 9 years. 9 years of monthly agony and failing to get answers or adequate treatment. We see health guidelines written with an unspoken assumption that the default body is a man's body. In fact, we actually call him default man. And in my view, he's, pretty much a 50-year-old white man from Pennsylvania. Women's pain is often dismissed, and believe it or not, 19th century attitudes about hysteria still inform the way that too many women are treated. Now, don't get me started on the stigma and the silence that surrounds issues like menopause and, as I mentioned, miscarriage, menorrhagia or heavy bleeding, and pelvic pain. It's high time that our nation and indeed the world had a serious discussion about women's health. Now, early last year, our government set up a National Women's Health Advisory Council, which I am very proud to chair, and this is to provide expert advice on tackling inequality in the health system. One of its first actions was a community survey of women's experiences in the health system. We called it the End Gender Bias Survey, and it received nearly 3,000 responses, and the findings, unfortunately, sadly not surprising, were quite grim. They leave absolutely no doubt that many women are not getting the care or even the respect that they deserve in our health system. 2/3 of respondents experience discrimination and bias when accessing the health system. And it's markedly more difficult if you experience additional disadvantage, such as women with a disability or women from or people from the LGBTIQA+ community, First Nations women, migrant women. Now, I've seen this medical bias play out in my own family. In fact, one of my own personal experiences was something that really set a fire in my belly about this. You may have heard me speak of this, but my own cousin, Risa, she was a little bit older than me, so in her early 60s, she went to hospital not feeling right. She had tingling in her legs. She felt a little bit unwell, restless, just feeling a bit anxious, and some numbness in her feet. She was sent home and told that she was just being a little bit anxious. They gave her some Panadol and told her to make an appointment to see her GP. She died that night from an aortic aneurysm, all alone in her apartment. And I can't help wondering if she'd been a middle-aged white man from Pennsylvania in a suit and tie and presented with the same symptoms, would she had been told she was just feeling a little bit anxious and to go home and take some Panadol. I can't help but think that wouldn't have been the case. We can't bring Risa back, but we can and we must do better for women and girls now and into the future. It's not a simple thing to change. There are centuries of biases, cultural assumptions and entrenched differences that must be contended with. But I'm confident that the Advisory Council's advice to the government will provide a huge step forward and pave the way for meaningful and lasting reforms. It's looking at gender bias across 4 focus areas of the health system: safety, research, access, care and outcomes, and empowerment. Now, research is an interesting area to look at because gender bias in research eventually leads to gender bias in education and training. And in turn, that leads to further gender bias when healthcare professionals work with their patients. Doctors and other health professionals are almost always dedicated and doing their best. And I'm not suggesting for a minute that there's some terrible conspiracy theory out there where people are out to get women in the health profession. That is not what I'm suggesting. But they do rely on what they are taught. They do rely on information that is given them. And they often rely on facts that are based on research that is skewed to a default patient, and that is our default man. I mean, the classic example, which I'm sure many of you know about, is heart disease. Men and women can have completely different symptoms of heart attack, and yet even today, many doctors do not recognise heart attack symptoms in women. To ensure we tackle some of these biases inherent in research, we've given the National Health and Medical Research Council a target to award an equal number of investigator grants to women and men. It is making a difference. Just as a quick aside, I recently met with the Council of Deans of Medicine in Australia, and they told me because of the research that has now been done around the way women present with cardiac events, they've actually changed the way they teach that symptomology to their students in universities now. So the research is very important. It is important that more women are recognised or encouraged to do research as well, because we know that women are more likely to do medical research into women's health issues. I take my point, my panel is my point. To create a front door to the health system for women who failed to get the answers they need, we've established a network, as an example, of 22 endometriosis and pelvic pain clinics across the nation. The clinics give women and girls access to accurate diagnoses and treatment instead of the runaround that's been typical for decades. We're also expanding the roles of highly trained nurse practitioners and midwives to improve access to healthcare outside major cities and to give women more choice. For example, we know that women giving birth in the care of midwives are less likely to experience interventions like caesarean section, instrument births, episiotomies and epidurals. We also support giving women more control over their health, especially their sexual and reproductive health. The ACT has made history by making abortions up to 16 weeks available free of charge. The Australian Government provides funding to the Australian Contraception and Abortion Primary Care Practitioner Support Network, which supports health practitioners who provide long-acting reversible contraception and/or access to safe, affordable medical termination of pregnancy. I'm seeing progress, and it's accelerating across Australia towards better health equity and better health experiences for women. But I don't just want this for our women. I want it for our women. I want it for women everywhere. We know that there are additional challenges facing women in the Asia-Pacific region. This includes access to contraception, higher rates of maternal death and morbidity, high rates of violence against women, and general lack of health workers to provide care. The Australian Government is committed to improve women's health and empower women and girls in the Asia-Pacific region. We're working in close partnership with Pacific countries in the region to support implementation of the Pacific Leaders' Gender Equality Declaration. This will accelerate action to prevent and eliminate gender-based violence and ensure universal health coverage for all Pacific people. Australia is also a key long-term supporter of sexual and reproductive health services and the promotion of rights in the Pacific region. Now, as I said earlier, women and gender equality are deeply entwined. Women's health and gender equality are deeply entwined. Our pursuit of gender equality is thwarted if women's health is not prioritised. I'm not suggesting I have all the answers, but I think good policy making depends on listening. We need to listen to the experts, clinicians, to researchers. We need to listen to women and hear their experiences, good and bad, in the health system. And I know I'm in good company on this panel and at this conference to listen. So thank you for the opportunity to speak to you today. I look forward to the discussion. Thanks very much, everyone.
Well, thank you very much, Jed, on so many fronts. I'm terribly sorry to hear about your family member. And of course, all of us would have experiences, personal or with someone we link to, who's been treated discourteously, insensitively or dismissively. And that is such an important aspect of fueling our work. But I think it's incredibly encouraging to hear from you about the Albanese government's initiatives. I'm sure people in this room will want to ask you about them in more detail, and we will all follow them with excitement to see what difference these can make. Our next speaker is Dr. Titilolo Duro-Ana, who is travelled to talk to us from Fiji, although, as she will tell you, she's an international citizen who was born and grew up in another part of the world. Her particular passion and interest is about sexual and reproductive health rights, as these are experienced across the life course. Dr. Titilolo.
Thank you so much.
Could you bring up Dr. Titi's slides, please? Here we go.
And we'll just use this on the next slide.
Yeah.
Thank you so much, Professor Jane Fisher. Thank you so much, Assistant Minister Jed Carey, for going ahead of me and all other panelists. Thank you all. I follow all the protocols observed, and I'll just like to speak on the area of how we can achieve health equity for women and girls, specifically in the Asia-Pacific region, but I'm focusing more on the Pacific where I live and I work. So I'll be focusing on two critical areas as I speak this afternoon, which have emerged in recent times as areas of concern in terms of achieving health equity for women and girls in the Pacific. Because I know we are only about 2.4 million, and we tend to be the ones left behind. So I'm speaking for those women and girls from the small Pacific Island countries this afternoon. Unfortunately, these two areas I'll be focusing on under the sexual and reproductive health and rights of women from the Pacific has not garnered as much commitment and progress as they should in the health sector. And these areas are health sector response to sexual and gender-based violence and eliminating cervical cancer in the Pacific. This slide shows you what is the current situation in the Pacific with regards, first, on sexual and gender-based violence. I don't know how many of us realize this, that the Pacific has some of the world's highest rates of physical and sexual violence against women. Compared to 1 in 3 women in the world, globally, that are exposed to sexual and gender-based violence or intimate partner violence, we have 2 out of every 3 Pacific women and girls that experiences sexual and gender-based violence. And we have some of the highest rates actually in 3 of the Pacific Island countries globally: Fiji, Kiribati, and Solomon Islands. And therefore, this leaves many of these women and girls suffering with the ill effects of sexual and gender-based violence, physical, emotional, and mental consequences. And that is why it's something that needs to be brought to the forefront and the spotlight shined upon it. A lot of investments has actually gone into sexual and gender-based violence from other sectors aside from the health sector. There's been a lot of work around addressing social norms on sexual and gender-based violence, training of the police, ensuring there are legal actions, having safe homes. But in spite of that, in the Pacific, we still have these very high rates, which shows that there's still a lot that has not been done. Why is that so? there is a missing factor, and the missing link is actually the health sector. Why do I say this? In spite of all the investments and the efforts that has gone into sexual and gender-based violence, we still see women suffering from these ill effects because the health sector has not yet responded as it should. We have not realized that this is something that we need to face and face squarely. The truth is that health workers are most of the times the first responders and sometimes the only point of contact outside the home for gender-based violence survivors. Health workers see them all the time. They come through their clinics. They come to their consultations. But what happens? They just treat the wounds. They treat the physical harm. They don't go on to identify what the real problem is. Help and support these women and ensure that they get the help that they require. Survivors have actually identified healthcare providers as the professionals they will trust most with disclosure of abuse if given the opportunity. Yet, the health sector across the Pacific is actually not service ready, and I'll explain what that means in the next slide. Actually not service ready to provide and manage gender-based violence. But if the full implementation of health sector response to sexual and gender-based violence happens in these countries, it will accelerate actually the elimination of this menace in the Pacific Island countries. We conducted a survey from 2020 right on to 2023, which is called the Health Facility Readiness and Service Availability Assessment across 794 health facilities in 10 countries in the Pacific. And the alarming thing was that, from that survey, is that there are less than 4% of health facilities in any of these 10 countries that meet the criteria for gender-based violence service readiness, because there's inadequate numbers of qualified staff to provide quality counseling, identification, and management of survivors, lack of private space for sexual and gender-based violence service provision, lack of adequate tools and job aids, as well as lack of relevant medicines, supplies to actually address, and commodities for the management of sexual and gender-based violence. It was a composite indicator. Putting all of this together, less than 4% of health facilities actually were ready to provide this service. The other important thing about it is that sexual and gender-based violence prevention and response is not integrated into primary health care in many of the Pacific Island countries. The service is mainly provided as secondary and tertiary level care. And the primary health care level is the closest to the community. So when they don't get the help at the time they require the help, they never get the help at all. And so many of these survivors actually don't get any help because they never get to the secondary, thank you so much, or tertiary facilities to receive the help. And that is why the preponderance is still so high in the Pacific Island countries. So it's time for the health sector, and I believe all of us, to rise up to this responsibility and begin to address this. It is urgent upon us, and urgent because of its impact. Not just the social impacts, but the health impact. Because when women are exposed to sexual and gender-based violence, their mental health suffers. Their sexual and reproductive health suffers. Death and injury happens. It's been shown that women that suffer sexual and gender-based violence are twice likely to experience depression, almost twice as likely to use alcohol, and to also 1.5 times more likely to acquire HIV, and more likely to contract sexual transmitted infections. It also shows that 38% of all murders of women globally were reported as being connected and by intimate partners. So what must we do? Because that's part of the questions. What must we do? First things first is that it must be acknowledged as a significant public health issue that requires a comprehensive rights-based health response. Secondly, health services are to be made routinely available for women and girls experiencing sexual and gender-based violence at all levels, particularly at the primary health level, including mental health care. Health work capacity needs to be built up. The health system needs to be strengthened for, first of all, identification, because that's where we miss it first. Identification, recognition, and provision of support to survivors of sexual and gender-based violence, including the ability to refer them for other further assistance, whether they need a safe home, whether they need legal services, whether they need financial empowerment. But it starts first from us. And then health sector budget allocations are made and disbursed for sexual and gender-based violence management. These are critical things that need to happen. I move on quickly now to the second one we'll be discussing in this presentation, and that's on cervical cancer. And I want to start this with this call to action, which was made in 2018, but is still very relevant and ring true today. It states here that 1 woman dies of cervical cancer every 2 minutes. Each one is a tragedy, and we can prevent it. I'm so glad to hear from Assistant Minister Jed that Australia is already on its way to elimination. But so sad to say that's not the truth that we face in the Pacific Island countries. This is the truth that we have in the Pacific Island countries. Cervical cancer is still one of the most common causes of cancer deaths among women in the Pacific today. The Melanesia and Micronesia regions, I don't know if you can see this graph on my right, still have some of the highest rates of cervical cancer in the world at 28.3 and 18.7 cases per 100,000 females, compared to the global average of 10.8. And that is why the Pacific Islands Forum, made up of Pacific Island leaders, that is the prime ministers and the presidents in the Pacific, in 2015 identified cervical cancer as one of the top 3 priorities for the region, but till date, still lagging behind. And why do I say that? In that same survey, I referred to the large-scale survey across 794 facilities. It shows that only 11% of health facilities in 10 countries surveyed across the region are actually ready to provide cervical cancer services. So in response to this scourge, in 2020, WHO, together with partners, developed the first ever global elimination strategy for any form of cancer. And that is the cervical cancer elimination strategy. Up till that time, there's been no global elimination strategy for any cancer, to just show you how important it is. And this strategy proposes an elimination threshold of 4 cases. Remember, with the Melanesia and Micronesia, we have above 20 per 100,000, bringing it down to as low as 4 cases per 100,000 women, achieved by implementing this triple implementation strategy, that 90% of girls are fully vaccinated with the HPV vaccine by age 15 years, that 70% are screened with a high-performance test, and what has been globally put forward, even in the strategy, is to have the HPV test, the DNA testing, and then that 90% of cases, whether pre-cervical or diagnosed cases, whether pre-cervical or cervical cancer cases, are actually treated. So it's been called the 90-70-90 targets. And this should happen by 2030. If we have this, that we can actually eliminate cervical cancer. Now, we supported 4 countries in the Pacific last year to adapt this global strategy to their country context and develop nationally owned cervical cancer elimination strategies. And the 4 countries are Solomon Islands, Tonga, Samoa, and Republic of Marshall Islands. By the way, I want to point out that Republic of Marshall Islands actually has the highest global burden of cervical cancer globally. We talk about bringing the burden down to 4 per 100,000 women, but currently, as I speak, Marshall Islands has that as 70 per 100,000. So it's a major burden for this small Pacific Island country. And they did develop these national strategies, which have been finalized, and some of the countries actually launched. And if you look at this slide, you will find that though the what has been put forward through the WHO Global Strategy is a 90-70-90 target. The countries, based on their resources, both human and financial, looked at the forecast of what can we possibly achieve. And so they domesticated this to what is possible for them by 2030. And you'll find that it differs across the 4 countries. So in gold, that's the one I have in black there, you will see, for example, Solomon Islands aligning to the global to say we can actually have 90% of our girls vaccinated by 2030. We agree to that. But if you look at all the other countries, you have variation between 80 to 85% set as goal. And then for the percentage of women tested for HPV, because currently as I speak, no country of this 4 is doing HPV testing in the public sector. So their goal was to have 50% of women tested by 2030. But they are not averse to increasing this if they get the support. But currently, based on their forecast and their current resources, they've set their target at 50%. And for percentage of those diagnosed with early stage or late stage cervical cancer, they actually all agreed with the global strategy and put their targets at 90%. But if you look in red, you can see how far behind these countries actually are to the targets that have been set. And this is a matter of concern to them, and this is showing the inequity when it comes to this area of health. What must be done? To reach this cervical cancer elimination strategy is the first place to start, because we found out that in a lot of countries there are pockets of work going on, but not coordinated, not in any way bringing together the resources. Sometimes there's duplication, there's overlap. And so the first place to start, which all of the countries have acknowledged, is to develop a comprehensive national cervical cancer elimination strategy aligned to the WHO global strategy. And in addition to that, and aligned to that, is to develop a comprehensive communication strategy, which will help to maintain confidence in the program and address stigma and misconceptions, especially in the community. And then establish a national HPV vaccination program to ensure sufficient and affordable HPV vaccines. Develop a national cervical cancer screening program with clinical protocols for primary HPV testing. Remember, I said these countries, none of them is doing this right now. To strengthen invasive cancer treatment and palliative care, and to establish monitoring and evaluation frameworks. One thing that also came out very clearly is that quite a number of them don't have a cervical cancer registry, or some that do, it's not fully functioning. So how can you tell what is happening? I want to end with these slides to say that the governments can't do it alone. It requires our joint action by all of us, multilateral, bilateral partners, civil society organizations, non-governmental organizations, academic institutions, the community's parents, and everyone at large. Let's unite to bring an end to all forms of health disparity against women and girls. Thank you very much.
So, thank you very much, Dr. Titi, for these incredibly powerful examples of what health inequalities can lead to, and how addressing them is not a single strategy approach. It does take collaborative efforts. And I think what we heard clearly this morning, it takes consultation with the community, inclusion of the community, and the fundamental importance of building trust. So we really found what you told us, I think, horrifying, but incredibly important and interesting. Our next speaker, Professor Caroline Homer, is Deputy Director, as I said, at the Burnett Institute, but she's a champion for the care of women who are pregnant or who've recently given birth, including in resource-constrained contexts. Caroline.
Thanks very much, Jane, and wonderful to have the opportunity to speak today at this very important event. I acknowledge that I'm on Wurundjeri country of the Kulin Nation and pay respects to traditional owners past, present and emerging. And of course, being a midwife, always think about the millions of babies who've been born, probably not far from where we are along the Yarra River over 65,000 years. And Aboriginal women and families have been growing up their babies on this country for a very long time. So I was asked to look at these three questions. How far have we come? How much farther do we have to go? And what's needed to get there? When I look at it now, it feels like taking children on a holiday, doesn't it? A driving trip. Of course, it's a lot more important and significant than that. I am going to concentrate on the global perspective. I know we are in the Asia-Pacific region. Most of my work is in the Asia-Pacific region, most of it in the Pacific. The Pacific are small countries with small populations, and so 1 or 2 deaths either side makes an enormous difference to their rates, to what's happening at their indicators at a global level. And that kind of makes it quite difficult sometimes to conglomerate them with the global numbers. They are also often forgotten, as Titilola has said, and the Pacific, I spend most of my time at big tables saying, and what about the Pacific? And what about the small countries in our region? When I talk about the numbers, I want you to think, as I think the Minister has very saliently reminded us, each one of those numbers is a person, has a family attached to them. A maternal death has a family. There's a partner, there's a mother-in-law, there's a mother, there's a community. A stillbirth has a mother, a father, a family, a community attached to that baby, as does a neonatal death. And each one of these deaths, there is a tragedy and a sadness around it. And we bandy numbers around, and you've heard some already this morning, and you'll hear more. But there's a lot behind those numbers. So the global targets that we talk about mostly in my world under Sustainable Development Goal 3, which is good health, maternal mortality, this is death during pregnancy, childbirth, or in the first 6 weeks after the baby's born, and increasingly up to the first 12 months after a baby's born. And this is whether the baby was born alive or was stillborn, and whether the pregnancy was to term or not. So a miscarriage is, women who experience a miscarriage and go on to die, of course, are considered a maternal death. Newborn mortality is death within the first 28 days. Skilled birth attendant is a really important global indicator, and in many countries in our region we are doing quite well, and the countries have made huge efforts, the Pacific Island countries particularly, to have skilled attendants at birth. Papua New Guinea is the highlight out of that, doing very well. The skilled birth attendant rate in PNG is about 45%. So 45% of women have someone next to them giving birth who knows how to care for them. And that's not necessarily a midwife or a doctor, that's anybody who's a health worker. So 45% is not okay. Unfortunately, stillbirth didn't get into the Sustainable Development Goal indicators, but is another indicator out of the Every Newborn Action Plan, is the stillbirth rate. And so these are the 4 key indicators that maternal health is engaged with globally. Over the last since 2000, the maternal mortality rate has come down, but it hasn't met any of the targets it's supposed to. It missed the Millennium Development Goals of a reduction of 75%. At a global level, we got to about 45% reduction. That's a long way from 75%. And essentially, in terms of Sustainable Development Goals, we're not going to get there at a global level. The global level is to reduce maternal mortality down to 70 per 100,000 live births. So Australia will be fine. Our maternal mortality rate global in the country is about 6 to 8, depending on the year. But in our Aboriginal and Torres Strait Islander women, it's about 5 times that. The numbers are smaller, they go up and down because of that, but 5 times more than the rate in non-Indigenous women. In the region, the rates are hard to know because, again, the numbers are small and most countries don't count them well enough. We don't do good maternal death surveillance and response across the region. In Papua New Guinea, the rate is somewhere between 200 and 900, depending on what you read. So that's a long way from 70 per 100,000 live births. Over the years, if you think about, Titi Lola said a woman dies of cervical cancer every 2 minutes. A woman dies of a maternal death every 2 minutes. It's 2 747s a day going down. 2 747s a day. 800 women a day die of a maternal death. Imagine if that was on the front page of the paper. Imagine the action that would happen if we knew that 2 jumbo jets of women died every day. So the graph on this side, we're not very good at left and right, but I think that's left. The top graph, the top line, it's been going down quite quickly. So that was in the first era, 2001 to 2005. We managed to reduce the maternal mortality rate pretty quickly. Mostly that was by lots of health workers out there in the sector. The next one is 2006 to 2010. It's a little bit flatter. The next one is 2011 to 2015. It's getting flatter. And sadly, the 2016 to 2020 is practically flat. And it's well above 70 per 100,000. So a lot of work to be done. Stillbirths, again, are coming down, and that's a good thing. We're actually saying the word stillbirth at global meetings like this. We're actually acknowledging that stillbirths happen and acknowledging to women that stillbirths happen. And I'm so happy to hear about the advertisement you saw, Minister, on the side of a bus, of a tram stop around miscarriage. Miscarriage has been hidden and women have suffered and experienced loss. And I'd like to acknowledge there'll be women and families in this room who have suffered pregnancy loss. And that's a tragedy for all of us and for our communities. So we still have a lot of work to do in both these spaces. Your first month of life, actually your first day of life is the most risky, but your first month of life is your risky time as a new person on the planet. 2.3 million children die in their first month of life in 2021, the last time we had the data. One of the biggest causes of deaths is preterm birth. And there's a big initiative globally around reducing preterm birth, ending preventable preterm birth. We know that in many countries in our region there are big rates of preterm birth, probably driven by gender-based violence, high rates of STIs and other non-communicable diseases. So preterm birth is something that we can do a lot about. We can address preterm birth if we choose to. And we can care for babies who are born preterm, particularly kangaroo mother-baby care, which wasn't invented in Australia, even though it has a great name. But now we know that if you attach babies to their mothers, wrap them up together, even really tiny weeny babies, they're going to do better. Take them out of the humidity crib, give them to their mothers. They'll have better temperature regulation, better glucose regulation, and they'll feed more quickly. Really simple interventions. It's terrible that we have to now do research to take away the technology and bring back parents as the key providers. The 4 Cs globally, this is from the Born Too Soon. Conflict, a huge problem at the moment in the world, and I don't need to tell you, I'm sure all of you read the news. Climate change, particularly in our region. These are the countries that are significantly impacted by climate change. COVID-19, we've seen significant reductions in maternal and newborn health care in the region, in immunisation. In some countries, the immunisation, vaccination programs have been decimated by misinformation and by fear, and we heard some of that this morning. And again, the cost of living, not only in our own countries in Australia, but of course across the region. Mahmoud Fatala was a professor of obstetrics and gynecology, and he was head of FIGO, which is the International Confederation of Obstetrics and Gynecology, for many years. He died in December last year. This is one of his very famous quotes, that women are not dying because of untreatable diseases. They are dying because societies have yet to make the decision that their lives are worth saving. And we have not yet valued women's lives and health highly enough. I think that's a very profound quote that he said in the 70s, and it's very sad that he died last year without this being fixed. It is an unfinished agenda. Women's health is the unfinished agenda going forward. What is needed? I've put up this slide. There's about 1 million reports that say what's needed. They basically all say the same thing. And this is just one example from from WHO, UNICEF and UNFPA's report last year. Commitment and investment. A commitment around equity, absolutely looking for those that are the hardest to reach. Service delivery for quality, accountability and partnerships, that's why these meetings like this are so important, and data. Unless we count things, we don't care about them. And unless we count them, we can't make a change. And for me as a midwife, service delivery is absolutely critical. We have to have a health workforce, and the Pacific particularly is struggling with a health workforce. The push to migrate, the push to find better places across the shores. Us in Australia, we have to be really careful we don't steal the health workforce from the region. Of course, people want to go somewhere where they'll have better opportunities, more money for their families, more opportunities for their communities. But we need to build the health workforce in the countries. And to deliver maternal and newborn health care, we have to have a health workforce. And for me, as a midwife, we have to have midwives. And we are working, and thank you to the Australian government for fantastic support to strengthen midwifery across the Asia-Pacific region, particularly DFAT support on strengthening midwifery in the 6 Pacific Island countries where midwifery education is delivered. And we know from this modelling study that I led a few years ago that if every woman in the world had a midwife next to her, we would have 67% less maternal deaths, 64% less newborn deaths, and 65% less stillbirths. We need midwives, we need health workers they can also work with, we need commodities, we need drugs, we need an ambulance, we need a telephone. We actually don't need very much technological things. It's not that complicated. But we need investment and we need commitment. And I'm really hoping that you'll take on this charge in your work going forward. And please do not forget maternal and newborn health. Thank you.
Well, a powerful call to action that we can all recognise, and certainly an area where there are terrible disparities between nations, including among our neighbouring countries. Our next speaker is going to take us to another phase of life. So Professor Susan Davis is going to talk to us particularly about women's health in midlife, and I think she'll refer probably to menopause.
So thank you very much, Jane, and it's an honour to be asked to be included with colleagues here today, so thank you, and to be able to speak about a topic that I think is important. But when I was sitting listening to the speakers who preceded me, I was thinking, gosh, it's still really hard if you're a woman to get to menopause. You know, you've got to get through potential nasty things in your life. You've got to get through sexual abuse, violence. You've got to get through childbirth. You've got to have access to health care, not get cervical cancer and other horrible things. And it is still really difficult to live to the expected age of menopause. And it's, when you think about it, in the 21st century, it's insane, really. These are my declarations. I do consult with pharmaceutical industry, and so I thought I should declare that. So the average age of menopause today globally is between the age of 47 and 51. And I went to my first World Congress of the Menopause in 1991, which shows you how old I am. And around that time, and really ever since, we kept being told menopause and all its symptoms, it's a Western condition. Well, there are a lot of reasons why it was a Western condition then and partially still now, and that's because partly you've got to live to get there, and partly because we see it from a Western prism too often. So in 1961, most women in the world didn't even live till the average age of menopause. So clearly, it was very much a condition that related to countries where you actually survived to over 50. By the year 2000, only 50% of women in low-income countries lived to the age of 65, which still meant that in 2000, the majority of the women in the world were not experiencing menopause. So again, only recently have we started to see it as a life phase that affects 51% of the population, because you've got to live to menopause to experience it. And I just add that we keep putting these European ancestry definitions on menopause. If the average age of menopause in Australia is 51, which it is, we call 45, under 45 early menopause, and under 40 premature ovarian insufficiency. It's in every textbook, every publication. If the average age of menopause in India is 47, which it is, you wouldn't call 45 early menopause. But we still keep using this label. If you read any literature that comes out of India regarding menopause, they still call 45 early menopause. It's not in India. We've got to realign the definitions we use with the global populations. But today, about 400 million women are at the relatively average age of menopause, or approaching menopause, or are peri or recently postmenopausal. The symptoms are listed. These are the cardinal symptoms. We've just done a systematic review of the world literature, and this is what falls out as the cardinal symptoms of menopause. And I'll go back to saying it's from a European ancestry prism. Dr. Rakib Islam, for his PhD in my group, did a really good, really cool study of menopause or midlife women's health in Bangladesh. And the top slide shows black as if you're premenopausal, grey as if you're peri, and white as if you're postmenopausal and through the age. And you can, I'll summarise it, but basically the prevalence of hot flushes and night sweats was virtually identical to what we saw in Australian women. And this was a representative sample across 7 provinces of Bangladesh involving 1,500 women. But what he also showed was that musculoskeletal pain was actually the predominant peri- and postmenopausal symptom. It is in most Asian countries. However, it's not considered in any of the guidelines as an indication for hormone replacement therapy. So why are we still focusing hormone replacement therapy on this sort of white Anglo perspective of the menopause? Why aren't we talking about the symptoms that are affecting women in a whole array of countries? The other thing that was really important in this study is Bangladesh has one of the highest rates of cervical cancer in the world also. And just before our study, the Bangladesh government had introduced screening, cervical cancer screening, across the 7 provinces that we actually recruited women from. And we found identically that only 6% of women in our sample had had cervical cancer screening. And one of the questions we asked was to understand why they weren't having screening. Was it religious? Was it cultural? And what we found was the specific reason that women were not having cervical cancer screening is that they couldn't relate to having a test for a condition you didn't have symptoms of. The single barrier was not the man letting the woman be examined by a health practitioner. It was, why would you have a test if you don't have a symptom? And that's why women were not having screening. But the flip side is the widespread misunderstanding of symptoms of the menopause in the community. And the internet's responsible for really good health outcomes and really horrible health outcomes. One of the bad things is confusing and putting out myths about the menopause. And you can go on websites and see that there are the 34 symptoms of menopause or the 52 symptoms of menopause, and women are saying, I must be perimenopausal because I'm tired, or I'm dizzy, or I've got headaches, not what we know to be the symptoms. But we really know that the symptoms of menopause often masquerade as other conditions. And we really need to get better physician education, community education, to really understand what happens to women at menopause. The other big issue is commerce piggybacking on menopause. So in the 90s, it was Big Pharma. Now it's just anybody who's got their nose in the trough. And I think this one is just, it's real, it's terrifying, and it's fascinating. Recently, globally, there was a world shortage of estrogen patches for the menopause, for hormone replacement therapy. And this is marketed in Australia. I don't exactly know what the company is. It's called the Patch Remedy for Menopause, and it's a patch. And it says to help ease effects of menopause. But if you turn it over, it's got a disclaimer saying, and I can't read the small print right now, but it basically says, this patch is not designed to treat any disease, condition, symptom, and there's no guarantee it will actually help you. And yet it's marketed to women, and women are buying it naively, not having read the small print. And it contains a whole lot of things that have not been proven to do anything for women. So women are vulnerable. There are all these predatory organisations prepared to act on women's vulnerability at the time when they feel that they don't know what to do, they don't know how to treat their symptoms. And it's being also fueled by social media and other commercial interests. We're getting headlines that my bosses were happy to destroy me, women are being forced out of work, that 900,000 women left the menopause work because of the menopause in the UK. Is this really true? Probably not. And this is one that really gets me angry. People you trust in, Bupa Healthcare paid for a research study into menopause and women's working and came out with a whole lot of biased, unsubstantiated answers, and then marketed a specific menopause treatment program, whereas if you pay £300, you can see a menopause doctor. There's no such thing as a menopause doctor, by the way. They're just people who are interested in menopause. And now there are companies all over the Western world, but it's going to happen everywhere, or developed higher income countries, with companies that will go in and make workplaces menopause certified or menopause friendly workplaces. But we don't even know what a menopause friendly workplace should be yet. We need to do the research to understand whether you're in a low-income country, a high-tech country, wherever you're living, how does menopause impact your ability to navigate your life, whether it be your family life, your caring for others, your volunteering, or your capacity to work? And we shouldn't be implementing policies until we have that information. Whoops, am I going the wrong way? And the other thing we need to understand better is how menopause impacts ageing. We do know that after menopause, women are at increased cardiovascular disease risk, increased risk of diabetes and bone loss and fracture, and we need to better define these long-term health risks and prepare women for the second half of their life, which is now being increasingly achieved across the world, better. So we need contemporary research. We need to understand the impact of menopause on work participation, and we need equitable access to healthcare for women with menopause, women with chronic disease, for chronic disease prevention, and equitable access to evidence-based care, which we do not presently have either in this country or, I believe, anywhere else in the world, particularly for midlife women. Thank you.
Thank you so much, Sue, for further really important food for thought and our need to be much more informed about inter-country, intercultural differences in these experiences and in the kind of healthcare that women seek and need. Our final speaker, Professor Cheryl Carcel, is going to draw on one of the things Sue referred to, which is prevention of non-communicable diseases. So Cheryl, as you know, is from the WHS Institute, and we look forward to hearing what she's going to tell us.
Thank you to the organizers and to Professor Jane Fisher for the opportunity to speak on this wonderful panel today. We've heard about maternal health, women's health, sex and gender-based violence, and cervical cancer, and I'm here to talk about non-communicable diseases and how, at some point this may intersect in a woman's life. So let me begin with these graphs that show the percentage of deaths and disability-adjusted life years according to the global burden of disease. And in the blue, you'll see non-communicable diseases and injuries, and in the red, communicable maternal, neonatal, and nutritional diseases, and dark blue causes outside of the top 10 causes of death and disability in women in 2019. So non-communicable diseases, or NCDs, are the #1 cause of mortality in women worldwide, responsible for up to 75% of their deaths in 2019. And more than 50% of these deaths were caused by two particular non-communicable diseases, which is cardiovascular disease and cancer. The other contributors you can see on the screen are chronic respiratory disease, respiratory infections, diabetes, CKD, and neurological conditions. But cardiovascular disease is the most common cause of death in all 5 socioeconomic regions of the world, and the leading cause of disability-adjusted life years in women. And this is responsible for up to 14% of lost years of full health. So given that the global population is living longer, non-communicable diseases are and will continue to be the biggest threats to women's health for the foreseeable future. And most of the diseases you'll see on the screen will have some disparities between women and men. And let me take one cardiovascular disease, such as stroke, as an example. There are sex and gender differences in sort of risk factors, diagnosis, treatment, and outcomes. For example, if a woman has hypertension, she is 30% more likely to have an ischemic or hemorrhagic stroke than a man who has hypertension, or a woman who is obese is also 30% more likely to have an ischemic stroke. When a woman has atrial fibrillation, there are a 3-fold increase risk of having a hemorrhagic stroke compared to a man. Then there are female-specific risk factors such as hypertensive disorders of pregnancy, gestational diabetes, and early menopause that increase the risk of cardiovascular disease. And so these risk factors are really not given much attention outside of reproductive health. In stroke, women are less likely to be given complete evaluations and are more likely to be diagnosed as having anxiety or a migraine instead of actually having a stroke when they are. They're more likely to have higher disability, and up to a quarter of women who've had a stroke are more likely to report poor health-related outcomes. And so this not only impairs their ability to have a fruitful life after that, but also to contribute to family, community, and society. And so addressing these inequities are all the more needed now. And so although when we think about non-communicable diseases, especially cardiovascular disease, we think about the older women. However, there's increasing evidence that across all life stages, women are susceptible to risk factors that ultimately contribute to non-communicable diseases. We contend that early education, timely initiation of preventative measures, and consistent risk factor management over the course of a woman's life is a strategic approach to prevent or delay the progression of many non-communicable disease. When these opportunities are sort of overlooked, there are substantial socioeconomic implications, and we know that preventative strategies are more cost-effective than treating diseases after this onset. And this is really in line with the Sustainable Development Goals of WHO, in particular SDG 3, good health and well-being, and SDG 5, gender equality. So this is looking at a figure on cardiovascular disease and cancer in a life course approach, looking first at preconception up to older adults. And it's really looking at what are the key risk factors in different life stages, as well as barriers and potential solutions. Going through a life course approach when we're treating non-communicable diseases in women is important because it places unique significance for women's health, in particular the reproductive years where pregnancy can carry far-reaching implications that impact both maternal and fetal health and beyond. And so allow me to discuss a few barriers on that previous slide, and in keeping with that previous slide, I've placed the barrier in red text and the green as solutions. We're thinking about poor prioritization of women's health in the clinical setting and in the wider community, and these both contribute to gender inequity. And I think we've come farther in cardiovascular disease when we compare it to other diseases, where we've seen there's a gradual increase in research publications relating to sex-specific risk factors, symptoms, pathophysiology, and treatments. However, there's still that gap when we're talking about having these findings, research findings, translated into clinical guidelines and actual practice. Women continue to be underdiagnosed and undertreated compared to men. And overcoming gender gaps in women's health is a huge challenge in many societies and require a big shift in community attitudes, including healthcare professionals. And there's really a lack of gender equity training with our healthcare providers. And a key example, as we've heard from the minister earlier, is that women's cardiovascular disease or heart disease are under-recognized and under-treated compared to men, and they're also less likely to be admitted and treated into hospital when they're having a heart attack. This emphasizes the need to establish gender health priorities, both globally, both government and non-government organizations. And recently, we've seen initiatives such as the U.S. announcement of the new White House initiative on women's health research, and the minister talked about the National Women's Health Advisory Council and also the newly established Center for Sex and Gender Health in Medicine in Australia. And these organizations provide important advice and recommendations to improve outcomes. And we also have to adopt gender-responsive educational strategies to inform healthcare providers and the public. And there's a need for having women's health clinic. In particular, my colleague in the audience, Professor Arnott, has a women's heart clinic in Sydney, and I think this is an important field to recognize when we're talking about non-communicable disease. And the next barrier is looking at the underrepresentation of women in clinical trials. When we do not have enough women in a drug and device trial, can we really say that these drugs and devices are as safe and efficacious for women? Drugs that are removed from the market for adverse events are more likely to affect women. Additionally, the potential risks of unborn and breastfeeding infants have led to the exclusion of pregnant and breastfeeding women from most trials. This really is more of a protective drive, but it has consequences that has led to issues with efficacy and safety of medications that are extrapolated from middle-aged women and men. And many of these medications in pregnancy are used off-label. The fair inclusion of pregnant women into clinical trials is particularly challenging, however, due to clinical and ethical issues relating to women and the fetus. And there's a drive now to improve evidence generation on the risks and benefits of therapeutic interventions for pregnant women. And this requires the inclusion of maternal-fetal experts in trial steering committees and ethical boards and additional safety monitoring during trials. There's also many other factors associated with poor participation of women in clinical trials, including trial-related factors such as restrictive eligibility criteria, suboptimal recruitment strategies, and consenting processes. And also the logistical burden of participating in trials. And this really needs to be thought about, because if we want women who are of childbearing age to come and participate in our trials, we have to think about all the other responsibilities they have in the community. And the last barrier that I'd like to discuss is looking at overall adherence rate to guidelines and the lack of continuity of care. And one of the things we know that guidelines adherence is bad or not good for both women and men, but it's even worse in women who have lower rates of assessment, education, and treatment for primary and secondary prevention of cardiovascular disease. And so in a systematic review, cardiovascular medication prevention in primary care, women were less likely to be prescribed aspirin, statins, and a certain type of antihypertensive medication. However, postpartum screening presents an important opportunity to identify the risks of non-communicable diseases and to provide education and awareness for both patients and healthcare providers. One of the trials ongoing at the WHS Institute is called Smart Health Pregnancy, and it's a low-cost digital intervention developed to improve postpartum screening and follow-up of high-risk non-communicable diseases, such as cardiovascular disease, after pregnancy in rural India. And the ability of care systems to reduce knowledge gaps among healthcare workers, which is what Smart Health is trying to do, and implement effective practices postpartum is really a major hurdle to overcome. And so how much farther do we need to go to achieve a health equity in women and girls? And these are some of the key priorities that needs to be addressed. We need to improve awareness of the risk of non-communicable diseases in women among the lay public, patients, and clinicians. We need to include the voices of women with lived experience, especially those in medically underserved and structurally disadvantaged populations, during research priority setting and design. We need to develop evidence-based strategies to improve the recruitment and retention of women in clinical trials, and this includes women from culturally and ethnically diverse background. We need to develop new models of care to integrate non-communicable disease screening and prevention into existing services for women when they're doing family planning and antenatal care, and strengthening these services so that they can deliver continuity of care. And finally, as we do our research, we also need to ensure that we are using an intersectional lens, so that not only do we need to talk about sex and gender or to take that data, but we also need to think about the age of this patient, the race, ethnicity, socioeconomic background, and educational background. And thank you.
Well, we've heard from extraordinary experts about the many areas of women's lives in which we need to do better to assure them of good health throughout the life course. We have a short period in which we're going to ask our panel to answer some questions. We've discussed with each of them so that there's no ambushing or things that are a shock when they come to be asked. But the question we'd like each of them to address is, from your perspective, what's the most important priority for reducing the health inequalities experienced by women and girls? What would be your starting point? And I'm afraid I have to ask you to address this very briefly because we don't have very much time. But I wonder, Jed, if you would tell us what you think.
Can I just talk into that?
As I understand it, you just talk.
Can I just? Oh, there we go. Beautiful. I've only got a few minutes, that's not fair. It's hard to pick one thing, but where we started federally, and I want to acknowledge there's a lot of work being done around the country. Victoria in particular has a fabulous agenda around addressing this issue, and I'd like to acknowledge that. We started with asking women and asking them their experiences, what would make it better, what they needed. And I think that's a really great place to start. And I know that we know a lot. We've heard a lot from the panellists here. We are building that knowledge, we're building that expertise, and we know where to go next. So I think starting with that is important.
Absolutely crucial, and I think as we've heard from you and other speakers, we need to make sure we ask a very diverse group of women.
Absolutely.
What are the things that matter to them? What would they like to have changed? Terrific, thank you. Caroline.
I absolutely agree with the Minister, and I think it's not only asking, we have to listen and do something. There's a lot of lip service that goes on asking consumer groups, but that's not my one thing, because I'm going to build on what Jed just said. So I think women have to be at every table where every decision is made. And it's not okay to have 80% men, 90% men around a table, and that women's issues infiltrate everything that we do. And I'm just thinking of the COVID response in the region, less so in Australia, but certainly in the region in the last 3 years. Nurses and midwives were often not at the table, but they were the predominant workforce who were going to deliver the services. So if you're not at the table, you're on the menu, and you have to be at the table. So we have to have gender parity across all the decision making, and that we can't have manels, and this is not a manel, this is the opposite, obviously, but exposing that, I think, is really critical. So listening to women, then ensuring that women and a diverse group of women are at every table, and the workers who are going to deliver the services are at the table. And in our region, nurses and midwives are more than 50% of the workforce.
So absolutely crucial reminders, and these sound to me like principles that apply to everything, not just to a specific health condition. Sue.
Okay, I'm going to be very clumsy articulating this, but I think we have to acknowledge that women are biologically different to men at every stage of their life, and that will affect their experience of health. And even being at the table, even women at the table have to be prepared to acknowledge that women will be different to men. And then we have to not just acknowledge it, but somehow respect it. So women, my experience as a clinician is that women are often seen, as we've heard, as being hysterical about situations because, if they come with strange symptoms, maybe it's their anxiety or their hysteria or their migraine. But we also have to somehow fit into that the hormonal fluctuations that do occur in women can make that possible as well. So how do we build it together that we truly can understand a woman's health experience without acknowledging the role of her biological difference and her hormonal fluctuations that will make her more vulnerable postpartum, more vulnerable at menopause, more vulnerable at puberty, etc. And somehow we've got to fit that together because men's hormones just go like this. And so we have to acknowledge that and accept it and build it into our healthcare management.
Cheryl, you've thought about this a lot and already given us some terrific suggestions. Tell us what the main one would be for you.
Thank you, Jane. There were a lot of priorities on that last slide. But if I was to pick one, and coming from my field, I think we need to have more women represented in clinical trials. And it's not just white Caucasian women who are more likely to join clinical trials, but we also need to be mindful of the LGBTQI community, of culturally and ethnically diverse women. And we need to do this because we need to provide evidence that these medications are safe for the women that we're giving to for the women that we're giving. And then we also, I feel like after we have this evidence, I feel like there is sort of an immediate need to translate this evidence into clinical practice. And I know sometimes, there's lots of publications that this takes 10 to 15 years to be translated into clinical practice, but I don't think we have the luxury of that much time. So I think it needs to happen now.
Thank you. Dr. Titi.
Thank you so. Okay. Thank you so much again for the opportunity. I so agree with all of my panel speakers. It resonates. But one thing I want to bring out, which we've heard already today, is local solutions for global problems. And in my experience, especially working across the Pacific, I have seen that there's no one size fits all. You need to sit and understand what's the context of each community, country, situation, and try to work on it. I so agree with women. I'm an advocate for all of that. And sometimes you look at a country like Papua New Guinea when it comes to gender-based violence, and we actually found out that women are their own problems. So designing the solution, we needed to work with women in a way for them to own. We have been the one actually propagating this menace, and we need, first of all, to deal with this problem before we even go to the men. And also I want to highlight something about multi-sectoral engagement in terms of doing that. We have found out that in a lot of the countries, like we said, women are not at the table. The men are the ones at the table, and like you said, evidence many times with policymakers, with religious institutions, might be what will make the change. And I worked closely also with a province in Papua New Guinea called the Western Province, and we know how against family planning that the Catholic Church can be, apologies, but working with them actually got to a point where by themselves the bishop of the archdiocese requested for us to come and train their nuns on how to provide family planning and take that forward. So I find that multi-sectoral engagement, getting different stakeholders to buy in, because many times the women might not be the ones to take that decision. So you need evidence to show them, advocate, and then they open the door for this to happen for the women, because it might take forever for us to get women at that table. But there are still people that are sitting at the table, and we need to get them to open up to allow equity for women to begin to happen. Thank you.
Well, I think with the voices of leaders that we've heard from today, more doors will have to open. But I think what we've heard reminds us that, as WHO tells us, our health is determined by the circumstances in which we're born, we live, we work, and we grow old. So what I take from this is the health sector has huge responsibilities. Some of these are responsibilities that have been neglected and that they have to take responsibility for. But there are all sectors of government that have a responsibility for health equity. And I think the wonderful thing about the initiatives we've heard from the Minister and others is we have to engage really actively with other government departments, with other areas of policy, with other areas of civil society, so that we can influence the circumstances that lead to women having poorer health, less capacity to participate socially, economically and politically, and that until we've achieved gender equity, we're not going to achieve health equity. But we've had wonderful food for thought, extraordinary opportunity to learn about circumstances of women's lives in Australia and more broadly, including in the neighbouring countries of our region. So I encourage you to join the next session, which is actually about an Australian initiative. It's about a newly funded centre for the elimination of violence against women in the Indo-Pacific, led by Professor Jackie True from Monash University, but including multiple partners from Pacific and other nations. And we hope very much that next time we meet in Australia, we might be able to talk to you about progress in some of these areas. Would you thank our wonderful speakers? I think now is the time for an afternoon tea break before the next sessions that start at 3.